Today we're going to be talking about the chronic total occlusions, the current techniques and approaches. But before we talk about the techniques and approaches, we have to define what a CTO is. So by definition, the chronic total occlusion is a occlusion that's been there for more than 3 months in duration with a TIMI 0 flow or TIMI 1 flow. So the morphology of a chronic total occlusion, these are complex occlusions that's been there for a long time, like I said, and they this is what you're going to find if you send this CTO to a pathology lab. This is what you're going to find. You're going to find a fibrotic proximal cap. You will find microchannels. You will find calcific areas. As well as the distal fibrous cup. So why we even bother in fixing these total occlusions? It's because we help these people have a better survival. Also, we improve their LV function, as well as we improve the tolerance of future RCIS. For example, if we open a CTO in the RCA. Same person, same patient has an MI 2 years later. This person is going to do better with this MI because he has compensatory flow from the other side. What are the patients? What are the patient care considerations for the nurses and techs here? We have to have these patients well sedated. Make sure you're well heparinized if you use heparin. We use Angiomax. You have to check in the radiation dose as well as the contrast. These are very long procedures, and you want to minimize the contrast. Complications I'm going to go over later. So what are the favorable characteristics? These are the things that makes us happy, as a tech. Instead of a 2-hour case, instead of a 5-hour case, it can be like a 2-hour case. So what we is a short segment, usually less than 20 millimeters, tapered tip opposed to blunt stump, no side branches or bridging collaterals. Straight segments, usually they're the easiest, LADs, RCAs, and functional CTOs, meaning there's microchannels that you can guide your wire. What are the unfavorable characteristics? Calcified, long segments, more than 20 millimeters, blunt stump, ostial CTOs, bridging collaterals, side branches, post bypass cases with diabetes. You know that these patients have a diffuse disease because they've been there for a long time, sometimes years. And the left circumflex usually the toughest because of the takeoff and angles. So axis is either single or dual. You'll do single when no collaterals are seen from the contralateral vessel, and you do dual access when you see the collateral vessels and are present. You can when you do dual access, you do either femoral or 2 femorals and 1 femoral and 1 radial. So the approach, I don't know. There's many algorithms out there. You probably heard about the hybrid algorithm. We have the Keeney algorithm. See here. So that's the first attempt is antegrade. Second attempt is also antegrade, and the third antegrade we go retrograde. If it's an ostial occlusion, sometimes the primary approach is retrograde. So this is what a table, CTO table should have. For the axis, usually longer sheets, 45 centimeters. The guide catheters, I kind of disagree with this because in here, what we practice for the CTOs, we we don't use 7 and 8 French guides. I would say that 95% of our guides are 6 French. And the reason it's we don't. First of all, you're gonna waste more dye. Second, you're not gonna use 2 stents, and 6 French it works good for us. The wires you have specialty wires, usually very aggressive wires like the Miracles, the Confianza, Progress, Gaias. And then you have to have microcatheters, Fine Cross, Corsair, and Turnpike. The guide selection, I think, is the key, because you have to have a lot of support. The shapes are the same. These are MAC guides. We use them 90. I can tell you that 95% of our guys are MAC guys from Boston Scientific, and the most popular ones are the VL guys for the left system, and the Lima and Amplats for the right. As well as the wires, we usually our algorithm in terms of wire escalations, we start with a filter, and we kind of test we have to see how the CTO is behaving, and from there we go from more stiffer wires like the Miracle 3, 6, Confianza Pro 12, and as the higher the number is, the stiffer the wire. When dealing with this tough procedures, you're gonna have complications, and the biggest complications are perforations. These are the three main types of complications: the main vessel perforation, and then you have the distal perforation and the collateral perforation. And you have to be prepared. You have to have coils on hand, or at least nearby. You have to have copper stents, gel stents, and as well as a pericalcinthesis equipment on hand. So I have a case, 59-year-old male with a history of all these risk factors, ischemic cardiomyopathy, suggesting a low EF. He was treated in another hospital, and they failed to go anti-rate. So he was referred to Dr. Kinney, and she was going to attempt to do a retrograde. And this is just the illustrations, so you guys can actually see. He had a mid CTO, and with the gold collaterals from the left. So the plan was going from the left, LAD, via septals through the CTO into the mid RCA. And these are the picture: RCA, RV branch, and you have a tapered tip here, which is, which they did try to go antegrade and they failed. So the plan was to go on retrograde. That's the LAD with some good septals. So before anything, you have to select the type of septals you're gonna be using. There are 2 epicardials and septals being the safest. And here is the dual injection, 2 guides, one in the left, one in the right. And you can see the septals fitting the RCA. So what are the steps? The steps usually are you have to select a septal, and then we usually go with a filter FC. FC stands for fine control, and then you can either use a Whisper or a Scion wire and a Corsair catheter. Make note, the Corsair, it has to be 150. There is a picture of the Corsair with a little puff of contrast. You have the Corsair with a filter FC. through the septals, going into the distal PDA RCA. So the second will be crossing the distal cap, and you're going to be escalating wires as needed. And here you cross the CTO, and the wire went on all the way into the RCA guide. So at this point, we have what we do is we advance the corsair into the RCA guide, and we trap the wire with a balloon. Once we do that, we have to use a Viper wire, a 335 centimeter Viper wire, to externalize the wire out of the guide. You have to remove the copilot from the guide, insert the wire introducer in the copilot, and after that, what we do is we do it's called the kissing microcatheter technique. You have a fine cross here, and you have a corsair here. You got to be careful not to connect these two catheters, because they can lag, and that's not gonna be good. Then you have to the fifth step is going to be the removal of the corsair, and then what you end up doing is you're going to actually, let me go back. You're going to open the CTO with you're going to go antegrade with you're going to use a exchange length wire, either a Melman or a Grand Slam, and you're going to that's what happened here. They have the stent, and that's the final picture with excellent, great results with excellent flow and distal RCA. In conclusion, these CTOs are very difficult lesions. However, complete revascularization can help patients clinically and symptomatically. Techniques and equipment continue to evolve, and step-by-step approaches like the algorithm that I mentioned are the key to help simplify these complex cases. Thank you.